You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. My guest today is Azizi Seixas. He's an assistant professor in the Department of Population Health at the NYU School of Medicine. So, Azizi, how are you doing? Thanks for coming today.
Well, thank you so much, and thank you for having me. This fantastic opportunity, and congrats to you on all the hard work that you've been doing.
Yeah, no problem. Well, tell me a little bit about your work. I know it's based on sleep, but the details are up to you. Tell me about what you do.
Sure, no problem. So I think let me provide a brief overview and explain to you and your listeners why is it that I'm interested in sleep. So ideally, I'm a researcher who focuses on behaviors that impact people's health. Particularly, there are four behaviors which I consider as four pillars of health. They are physical activity, diet, stress management, and sleep. And so that's the reason why I focus on sleep, because of the four, sleep has been shown to be implicated in cardiovascular disease, cardiometabolic health conditions, brain health, daily function, and just quality of life. And so that's the reason why I focus on sleep, because I take a broad and holistic view of the individual, looking at the individual over a 24-hour period, of which sleep is important because we spend on average about a third of our day sleeping. And so I also look at how sleep impacts physical activity, diet, and stress management, and how those impact cardiovascular disease, cardiometabolic health such as diabetes, obesity, hypertension, and brain health. And brain health I define as mental health as well as aging-related diseases such as neurodegenerative diseases like Alzheimer's disease.
So it's very expansive what you said, so let me break it down a little bit. So what's your general approach? Is it so individuals come to you for help, or do you have a program that is disseminated to a vast number of people for use?
That is an excellent question. So what I provided earlier was just a broad stroke in terms of what I'm interested in, but in terms of my day-to-day activities and my work, I am really interested in looking at sleep, physical activity, and diet as prophylactics. What does that mean? Can they prevent the onset? Can they be used to help better manage people with some chronic diseases? So what we generally do is we have a focus on hard-to-reach disadvantaged communities throughout the country, but we're primarily focused on the New York metropolitan area. What we do is we go out to barbershops, beauty salons, what we consider as non-traditional research locales. We recruit participants. Oftentimes recruitment is very non-traditional. We'll go to a health fair. We would hang out with barbers and, beauticians and, tell them about the condition that we are, our studies about, particularly sleep apnea and hypertension. And we increase health literacy and information about that. We consider those strategies to have high impact penetration in the community. What we then do is that we screen these participants who might be at risk alongside credible messengers in the community, which is why we go to the barbershops. We go to people from faith-based organizations because they are more likely to be heard from participants, people in the community. Once we then do that, what we do is we say, okay, if you are at risk, here's what we'll do. Here's a curriculum, and we have different forms of curriculum that provides content, text messaging, and videos that help people to be better informed and help them through the continuum of care, whether it be the continuum of care for sleep apnea or the continuum of care for hypertension or diabetes. And so what
Let me ask you,
sure, go ahead.
A quick question here. So I know, from my own self, most people don't know if they're snoring unless someone else tells them. They have no idea,
Yes.
Or if they have apnea. So when you talk to these people, are you looking for people that have medical conditions and you're saying to them, hey, it may be because you're not sleeping well? Or is it people that, are you just saying hey, because I see you're overweight or something like that, I guess you'd be more gracious, or you're this or that, and you may be predisposed to these sleep conditions, which would lead to these health conditions. Which angle do you take that works well with people, and which angle where they say, get out of here and leave me alone?
Sure. Great question. So our approach is at the community level. So we screen a wide cross-section of participants, and generally, if you're a healthy-ish kind of looking person, we'll approach you, and if you're interested and you want to hear about what we're doing, then that person can be eligible. We sometimes go to clinics, but what we've found is that those settings may not be the most opportune. Yes, these people are already primed, but oftentimes what we see is that they don't want to listen to us at that time because they're so busy. They want to go in and out. However, when we are in their territory, in their setting, in their natural habitat, and I'm sorry to be using those terms, but in many ways we look on it like that because it's really about someone's ecology and being almost like an ethnographer. And we go to them and we say, hey, what do you know about sleep? And they're like, well, I'm always tired. Or someone might say, I know nothing. And when we start talking to them about it, and they're like, wow, I didn't know that. And I say, would you like to be screened, if you're at risk for sleep apnea? Sometimes people don't know what that is. When we talk to them about snoring, oftentimes what we realize that people think, especially people from outside of the United States, that, snoring is a sign of good deep sleep. And so when we demystify that, they're like, oh, I didn't know that. And then they start reflecting, oh, my uncle snored a lot, or my aunt snored a lot, or my husband snores a lot. And so they start connecting the dots. And so even though that person may not be at risk for sleep apnea, after we've screened them, they actually serve as conduits, referring other people who they believe might be at risk. And so it's almost as if we're creating like an ecological social network, right? Where just by sharing with those individuals right then and there, they start connecting the dots. And so that's what the true impact of community engagement. And what we do as well is, before we go ahead and do all of that, we have a community steering committee. Now, a community steering committee, it consists of about 6 to 8 individuals, where once we decide to launch a project, they are actually beside us in the planning process. And they say, you know what, we think you should actually go to that particular location. Oh, I think this church or this mosque actually might be better for you. They come along with us and they help us to determine what are the best strategies to impact people, to get people interested. And so we've had tremendous success over the last 10 years doing that. Myself and Dr. Jordan Jean-Louis and some of my other colleagues at NYU have done really pioneering work in that respect.
So what does that mean, success? Like, you educate people and all that, and you help them evangelize about sleeping well. But, what is success to you? Is success finding people that have sleep apnea?
That's a great question. That's a great question. So here's what we consider it, and I think there are two different forms in which we can determine success: qualitatively and quantitatively. Let's talk quantitatively. So we actually just did our own inventory at NYU, where we have, over the last 6 years or so, we have done about 3 or so projects. We have actually provided sleep health information to over 3,500 individuals throughout New York City. And that is deep impact. And what I mean by that, it doesn't mean we just counted heads in a group of individuals. No, these are individuals who actually got pamphlets about sleep health, and they chatted with us for about 15 to 20 minutes about sleep and their risk for sleep apnea, insomnia, and other sleep-related disorders. Here's another way in which we consider success. One of our projects, we've recognized that, sometimes participants or people in the community don't want to hear from medical professionals. So what we've done, we have trained a cadre of over 30 community health workers who actually are trained on sleep health education, and they actually serve as the engine behind one of our NIH-funded clinical trials, whereby they're providing sleep health education as well as social support that allows participants to navigate seamlessly the sleep apnea continuum of care, which can be very complex and arduous. Let me explain why. So when someone is determined that they are at risk, the probability is very low. Why is that so? Oftentimes, it's twofold. Many people are not as educated about their risk for sleep apnea. So when they go to their physician or their proper medical providers, they never usually ask. They might say they're fatigued, and that's the only way in which those questions or those issues actually come up. What needs to be reciprocated from medical professionals when someone asks, when someone reports fatigue or anything like that, is, what is your sleep pattern? And generally, we've found that medical professionals, because one, they're just so busy and they're just going through and trying to get everything checked off, that they don't ask. Additionally, what we've found is that medical professionals aren't well versed or well trained in sleep health. And so even though they may have the intuition and inclination to ask such questions, they don't have the necessary training. And so they oftentimes don't address it, or they may just give very vague health hygiene tips, which aren't oftentimes very helpful when they're not actually wedded to some very robust, sleep health curriculum. And so when you have patients not sharing or not asking, and when we're having providers not providing the necessary resources, what happens in that first phase of screening is that we find that a lot of folks don't get screened for sleep apnea. So here's what we do. We have our community health workers, or what we call peer sleep health educators. We actually have them do that. So we remove that pressure, we remove those responsibilities from providers. We give that to community health workers, and they spend time, and they are assigned participants, people who are at risk, and they walk with them and they talk with them about their risk and connecting the dots. So, for example, what would this look like? So Mr. Jones, who has hypertension over the last 5 years, he's been on several classes of antihypertensive medication, but somehow, his blood pressure still remains high. What's going on? Mr. Jones does not realize that he actually has sleep apnea, and that might actually be suppressing the effect of his hypertensive medication. So what we have our health educators do is to connect the dots and to show the person, hey, perhaps the non-responsiveness of your blood pressure to that antihypertensive medication may be as a result that you may have untreated sleep apnea. Let me help you find the words to go to your providers and look about that. If they don't want to do that, and if they want to enroll in one of our studies, we actually facilitate that. So here's what we do, what we found as another bottleneck. We realize that when people do say, hey, I would like to actually go to the physician or the provider and get treatment. Oftentimes where we find that people fall off is when they find out that they have to do a sleep study in some weird, mysterious place at a clinic. And you're like, I don't want to leave the comforts of my home. Is there a more convenient way?
I can give you a quick anecdote on that.
Yes, please.
At one point, I was going to go for a sleep study, and they wanted me to be there and go to sleep at their place at 9 p.m. And I go to sleep usually at like 3 in the morning. And I don't have my pillows in my bed and all that, and be connected to all these sensors. And I said, hell no, I'm not going to sleep at all. That's not going to be representative of what would happen with me.
Exactly. And so, and I appreciate you sharing that, because we find so many people telling us that. And even though we have partnered with clinics whereby they can bring, pillows or any other thing that would make them be more relaxed or more comfortable. Sometimes, we have, spouses, they're able to attend. But what we found is, and what we decided to do was, we said, you know what, let's make a home-based sleep study part of our workflow. And that was guided by, debriefing from previous studies where we found that people dropped off. They were screened, but they didn't go to the clinic, and they're like, hey, doc, I really don't want to do this. And as you rightfully articulated. So we have a home-based study to do that. And so we have a 7-day home study. Participants wear devices that checks oximetry and determines risk for sleep apnea. What we've been finding is that about 90% of the people who actually do get, screened, that they do have elevated risk for sleep apnea. So what we want to do, and we find that this is a very good strategy, is that there are some people who probably don't need to go to the clinic. Let's weed those out with a home study. And so that's what we've been able to do. And so we've had our health educators encouraging people to say, yes, I want to participate in a home study to determine risk. And so when we have identified them to be at risk based on a home-based sleep study, then at that point in time, we refer them. By then, they're already engaged in the process, and they realize that this is a serious thing, that my snoring wasn't benign as I had thought, but it's actually a medical condition. And so when we actually then refer them to a sleep clinic, they're already primed, they're already engaged in the process. And so what we've done is that we have partnered with sleep clinics throughout the New York metropolitan area to assist people to go to the sleep clinic to, one, get diagnosed, as well as, if they are diagnosed, to get referred in terms of a customized treatment. So if it's CPAP or some kind of oral device, or sometimes surgery. And so that's what we've been able to do. Now, we've also found that there's another bottleneck. So when people are diagnosed, here's what happens. They may actually get the CPAP, but here's what happens, especially within the first 2 weeks to 4 weeks of the CPAP. And CPAP is a continuous positive airway pressure device.
Right.
So what happens is when the DME companies provide the CPAP machines, what we found is that our participants, and not to their fault, they just take for granted that whatever air pressure they were customized at in the clinic, that is the setting that it will be on when they receive it. And so what we've had the health educators do is to educate them and say, this is like a regular medication. You need to read the bottle. You need to ensure that whatever referral or prescription that you got, that is what the setting is at. And so we empower our participants in that way. And it's critical they do that because oftentimes many studies have shown this that the initial rejection of CPAP is partly due to the incongruency in whatever pressure was actually assigned during diagnostic tests and the pressure that was set on the CPAP. So there's this disconnect there, and so either the pressure is too high.
Why not assign like a CPAP buddy, someone that's had one? You're doing evangelists, so why not see if you can get volunteers or incentivize somehow and people that have CPAPs, that whenever a new person gets a CPAP, they work with someone that has a CPAP for months or years, and they can give them advice and tricks.
That's a great idea. We do that as well. So some of our health educators have sleep apnea themselves, and I know a couple of our other colleagues at University of Arizona have done that, where they've created a peer buddy system as well. And so that's a great idea. We've piloted it, and we've had tremendous success, as well as some of our other collaborators at the University of Arizona have done so and has had significant successes as well. So that's a fantastic idea. One of the things that, just to kind of finish up quickly, is that when people do get CPAP, what happens is the first 2 or 4 weeks they may reject it for several reasons, and we have the health educators help them through that process. But then what we have them do is that we want them to also help these participants and these individuals to increase their chances of adhering. So what we've done is, and a couple of the work that I've been working on is, we've tried different strategies. We've tried health educators. Now we're in the space of digital health, and this is an area of mine where I use artificial intelligence and machine learning to do so, whereby we're providing personalized messaging and curriculum to individuals so that it may optimize their level of adherence. So that's kind of the space that we're getting into now, because one of the things we realized was, having health educators is great, but man, if we're supposed to have a scalable intervention, like, we need something that is going to be more agile, something more nimble, and something that can be far-reaching. And so we're trying that approach. No, we don't have any results yet, but I think that it's going to make a significant impact on the level of adherence, which is a huge thing. A huge thing when it comes to CPAP machine, where particularly people in the space of cardiovascular disease, they believe that the evidence on the cardiovascular benefits of CPAP is still up in the air because of a international study, a multi-site study called the SAVE trial, that showed that it didn't have as much cardiovascular benefits, but it had in terms of patient-centered outcomes, whereby it reduced sleepiness and improved quality of life. The caveat being, though, for that study is that when they looked at the average level of adherence of those people in the study, they only used a CPAP machine for about 3 hours. So essentially, and if you could follow me here in terms of the logic, essentially, if someone has sleep apnea and they only use a CPAP machine for 3 hours, it means that that person is only getting 3 hours of good sleep, hypothetically at most. Show me anyone who's healthy who gets 3 hours of sleep, then I am convinced. So that's one of the.
One quick question: what are they doing? Is it the first 3 hours of their sleep, and they say I can't take it, and they take it off, or is it the end of the sleep?
Good question. It's a combination. Some people get frustrated and can't tolerate it, and they take it off, while some people actually fall asleep. Right? They fall asleep in the couch, and when they wake up, they realize, oops, I didn't put it on, and then they put it on for the remaining time that they're asleep. So there are many different reasons why that is so, but those are the 2 primary reasons that explain, the low adherence usage of CPAP. But I can tell you this, though. There have been other studies done, published in JAMA, particularly the Hipparco trial, that when people actually did use the CPAP machine for 4 hours and more, significant improvements in cardiovascular disease. Blood pressure levels dropped, their lipid profiles were improved. Fantastic. So it shows that CPAP does work, but it only works if you adhere to it.
It's funny. I thought as you were talking, since you say you deal with churches and barbershops and all that, if you had shills, like you had someone in the audience, at a church, and you pay them to go there and they deliberately start snoring during the sermon, but it's all planned. And the preacher stops and says, "You hear that?" And then talks about the importance of sleep.
Yes, that's funny enough. So I had a colleague who tried to do something quite similar. I have several colleagues, but with regards to stroke, whereby they created these elaborate videos, and they've tried to find text in the Bible that focuses on sleep to show that sleep is very, very important. And so you have to be creative to reach people. Ultimately,
Right.
It's really behavioral change. How can you change behavior? How can you get people to say, hey, yes, I have this issue. Yes, I'm going to seek the necessary treatment. Yes, I'm going to stick with this treatment. It's all behavioral. Yes, it's biological. Yes, it's medical. Yes, it's clinical. Those are just outcomes, right? And so some people may not even care about what we found is that there's some people who say, oh, yeah, blood pressure, yippee, whatever, I don't care. And I'm being flippant about it. They care more about how the sleep impacts their quality of life, their sex drive, the headaches that they would normally get. Those are on their memory, being able to remember things, being able to not have this cloud over them, this idea called brain fog. People care more about that. And if you tell them, hey, if you use this or if you treat whatever sleep issue or whatever, hey, yes, they're more likely to use it. And I would too. I wouldn't blame them.
So it sounds like you're testing and piloting and working your way towards a better and better solution. So what's the new stuff that you're going to be trying out over the next 6 months or a year? And what do you think is going to make like a huge leap forward in the number of people you can help?
Sure, good point. So I alluded to it earlier regarding in the area of artificial intelligence, machine learning, and mobile health. In terms of my work, I discussed, we're really interested in improving and optimizing adherence to treatment. In this case, sleep apnea treatment, i.e. CPAP. And so what we find is that we want people, similar to a Netflix profile. Netflix learns the type of movies that you like, the genre of movies that you like. What we want to do is, instead of just throwing the kitchen sink at everyone, we're discovering and we're testing novel strategies, novel information, novel content that will improve and optimize adherence. It's a personalized approach. And we have a very elaborate strategy to do that. It's an idea that we've come up with at NYU. We're happy to know that these are some principles that have been used in marketing science and artificial intelligence. And so we want it to be fully digitized. So when someone gets the CPAP machine, we want those messages to have continuous data streams. We want those to be connected with their wearables as well, and to provide these personalized messages and strategies that can give people a high degree of insight as to how their actions impact them in the immediate and long term and over a period of time, as well as using those insights to help modify behavior, particularly having them lead healthier lives and to really strive for wellness.
Okay, very good. Yeah, one thing to point out to you is you said you've counseled about 3,500 people, but each of those people have families and they know, I don't know, on average, how many other people. So the number you probably impacted, I would say, is triple that, maybe 4 times that, if it's done right.
Yes. I think you're absolutely right. And, gosh, we would love to do a social network of this, whereby we want to be able to, and we've kind of done this with our health educators, because in many ways, if you look at our health educators as a part of a network. These are the very nodal people, what we call social influencers. And so if we can train more of those people, if we could prime more of those people, can you imagine if we have these people on social networks, being ambassadors for sleep health? Can you imagine how many people they can reach just digitally and through the internet? But then at the same time, you're right. Talking to Miss Jones means that we probably would have spoken to her spouse, her children if she has any, her mother, her parents. It's far reaching. It is far reaching, and I hope too through this podcast that it could have a ripple effect as well. Because sleep is important. Unfortunately, it's one of the most silent behaviors, but also the most impactful. Something I always say, to get people to turn around their sleep strategy and how their attitude about sleep. I tell people, your day starts with sleep. Your day doesn't end with sleep. Because the sleep that you get the night before impacts everything the following day. It impacts what you eat for breakfast, how you metabolize at breakfast, how much energy you have. Do you want to play with your kids? Do you feel like, man, I hate my boss? You feel irritable? Those are important things, right? And so your day starts with sleep.
Yeah, that's what I was going to ask you is, right, what conditions are affected by poor sleep and the non-obvious ones? So maybe if you can just give a list like you gave before, the obvious ones or the ones that are obvious to you, and then the ones that are like really surprising to people.
That affects their sleep?
When they have poor sleep, what does it do to them?
What does it do to them? Okay, thank you.
Yeah, again, some obvious effects that we've, like you can list them, clinical effects, medical effects. And what's some non-obvious ones? Non-obvious ones.
Yeah, but headaches. I mean, headaches are important. I mean, I know in my family, folks suffer from headaches. And what we have found with this particular family member is that when they have turned around their sleep habits, that they no longer have these headaches. And the doctors were trying to figure out, was it migraine? Was it this? Was it that? And just by shifting around, getting more sleep, going to bed earlier, impacted it. So headaches is an important area. They're tolerable enough, but they're annoying enough, and I think people respond to that. Sex drive, libido, it's huge. I mean, that's one area that, especially when we speak to both men and women, all genders, that is important. That having more sleep means that you have more of an appetite. That is absolutely crucial for people, especially when people are relational. Just in terms of people's attitude towards just life, and I know this is more existential, but as I said, when you're sleep deprived, that it impacts your mood, it impacts your cognition, and when you put those two together, man, here is it that a dark, dreary day can be the worst thing ever, or it could just be a nice, crisp winter day. And so those are some areas in which sleep deprivation impacts. It also impacts your functioning, your ability to think and to learn and to process new information. This is critical, and I've suffered from this. Whenever I'm sleep deprived and I'm trying to write something or I'm trying to write emails, oh man, I feel like it's a struggle just to string along sentences. Those are some critical areas. It's key. The one thing I've also found too is your reflex, and I'm giving non-traditional because everybody knows about the big ones, the health ones, right? But your reflex,
that's why I want to ask you.
Yeah, your reflexes, either in terms of your gait, in terms of how you walk. I mean, when you're sleep deprived, you really don't walk very straight. You're more likely to have falls. That's key, right? Your reflexes when you're driving, they're highly suppressed when you're sleep deprived. Those are huge things. Those are absolutely critical. And so we actually speak about these things because when you talk about hypertension, it seems like this distant disease that oftentimes people say, oh, not me, I don't have hypertension, and it doesn't really hit them. But when you talk about everyday functioning, that's when you get people. Because when people hear that, they're like, oh, wow, that's what that was? I couldn't concentrate. Oh, wow. And so, when we share this with people, they're more open and more receptive. And they're more likely to change their behaviors. And if they don't change their behaviors, and to use your word, they evangelize, and we love that.
Yeah, what I've learned is if I don't feel good for whatever reason, I'm not a good husband, I'm not a good father, I'm not a good friend,
Yes.
I'm not a good coworker. It affects all your relationships. So,
Yes.
bad sleep is the exact same thing. Like you unintentionally are, short or mean to the people around you, and it just affects everyone around you. So
It is. It is. And I am not telling your audience that you need to go around and say and explain away the reason why, you're a bad husband or spouse or you make everyone's life miserable. I am not saying that, but it is a huge contributing factor because you're not patient. You cannot be patient. If you're sleep deprived, you're not going to be patient because patience is not just an emotional, relational thing. Patience, if you want to look at it scientifically, you are exercising some high level cognitive functioning. Somebody's saying something to you that is annoying and you just disagree with. And so how are you going to respond to that? You could tell the person, yes, you're the worst. You have no sense at all. You could do that, right? Or you could say, let me try and process what this person is trying to say and let me provide my best suggestion and interpretation lovingly. There's a lot of cognitive juices we have exercised just to do that. And so when you're sleep deprived, you don't have the bandwidth to do it. You don't. And also, another area, just to be health related, and I oftentimes say this, and I see this with my kids. Whenever my kids are sleep deprived, I know this, especially in the wintertime, they're bound to get sick because it really diminishes your immune system. And oftentimes people say, oh, yeah, I need to do this, I need to do better, or I just need to exercise. And exercise is good too. But do people know, and I want your audience to know this, is that, if you don't get enough sleep, the health benefits that you would get from physical activity is actually diminished. If not, it can be even reversed. By that, I mean physical activity and exercise can be stressful on the body if you don't get enough sleep. And there have been studies that have shown that where people, they're sleep deprived and they exercise religiously versus people who slept and exercised the same amount, who had better health outcomes, the people who slept well and the people who exercised, not the people who didn't sleep well and exercise. So it goes to show that those positive benefits that you can get from physical activity can be reversed, if not suppressed or thwarted by lack of sleep. People don't know that. And so that's the kind of work that we're doing, at NYU.
Okay. Well, very good. Well, we're out of time, but what are some resources for listeners? So if they live in the New York metropolitan area, what are resources for them? And what if they're outside of that area? What if they're outside of the area? What do they do then?
Sure. So always they can contact me, Azizi Seixas, NYU, Langone Health, or, they can go on our Facebook page at NYU. In addition to that, if there are more national websites, National Sleep Foundation, National Institutes of Health, American Sleep Apnea Association, those are some wonderful, 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 wonderful resources that people can actually get a lot from. And I'm on Twitter as well, at Seixas Doc. It's at SEIXASDR. happy to chat with anyone if they have any questions about sleep or health-related issues.
That's great, Azizi. I appreciate you coming, and I love your novel approach to this, and thanks for being on the podcast.
Thank you. Keep up the fantastic work.
You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you.